Hello, I'm William Zoghbi, and welcome to our Multi-Modality Imaging Conference. Today we're going to talk about ultrasound enhancing agents. We used to call that contrast echocardiography, but I think it's much more appropriate to think about them as ultrasound enhancing agents because their application is not only for echocardiography, for multiple other uses that we can talk briefly about. And so these guidelines or clinical applications of such have been updated, and we'll share that with you. So what I would like to address today is the technique, because it is for the uninitiated, this is a technique that can be affected by your ultrasound imaging settings. So you want to optimize those settings for your ultimate applications of what you're looking at. And the impact on diagnosis and clinical management, which I think have been quite impressive. Now for agitated saline, I think we still use this because this is important for detection of right to left shunting. Take a look at this nice example of a patent foramen valve. You could see the bulging of the interatrial septum and the transient occurrence of contrast that we could see on the left side. These have been nicely evaluated actually in the Journal of the American Society of Echocardiography recently. So I would like to refer you to that. So we still use this important diagnostic modality. Also, we use it for enhancement of Doppler signals when it's important to get a pulmonary artery systolic pressure. Even though you barely see a tricuspid regurgitation jet, you can enhance it with saline contrast or any of the newer agents. So when we talk about these agents, there are multiple factors that affect these tiny microbubbles. And the way we get this contrast effect is these tiny microbubbles reflect ultrasound, and then that's how we detect it. So a lot of research for many, many years have occurred in this science. And, some of these have affected, the shell of these tiny microbubbles, what kind of gas the content of this gas is and how robust it is. And all these gases are inert, so they don't have any untoward effects to sustain significant arterial pressure, particularly when you are on the left side of the circulation. In the United States, we have 3 approved ultrasound enhancing agents, Optisound, Definity, and Lumasound, and some others in European countries and throughout the world, and some who have had a lot of investigation, if you will, but really never made it, although they had some nice properties, if you will. And you could tell also from that, I'm going to go back to that slide, that the size of these microbubbles are really tiny, so they don't impede movement of blood in the capillary circulation in the small venules, and that's how they basically cross the pulmonary circulation to go to the left side and even have perfusion imaging throughout the body that you could image these enhancement of contrast. Now the power of ultrasound enhancing agents is really amazing. Just take a look at this example. Usually you don't like to show such studies, but take a look at this example. This is from our early experience. You could see that all of a sudden the light shines on your heart, and you could see the cavity very nicely to evaluate its size, its function, regional as well as global. So the powerful impact of such modality is crucial. And I emphasize that because, yes, we can get some reimbursement for these contrast. This is not a money-making machine, by no means. So the driver for such utilization is really the quality of the images, particularly to answer the clinical question that you're aiming for. So it is, the champion of quality in a laboratory that would push appropriate utilization of ultrasound enhancing agents for such. So let's talk about technology a little bit, and what do you expect? Now, if we inject contrast, and I'm going to try to show it here, if we inject contrast, you're going to see some enhancement on the right side of the heart. This is where the right ventricle is. But what you will notice also is that you barely initially see the right ventricle because of attenuation of this contrast here. Also notice that if you inject too much, I'm going to give you here a large bolus, rapid bolus. If you inject too much, the reflection of ultrasound will be predominantly in the area of the apex, and you'll have so much shadowing and you won't be able to see anything because most of the ultrasound beam has been reflected. So let's take a look at that after an injection. And here this starts coming on the left side of the heart, and notice that it builds up, and then gradually you'll see more and more blackness, and the blackness means that you have so much contrast here at the tip of this heart. So dilution of some of these agents is important. A slower injection so you avoid attenuation, right, is crucial. Otherwise you're not going to be able to interpret these studies. Also, some of the settings on machines are mechanical index, which is basically the power of ultrasound that is sent, of the energy of ultrasound. Now, because as you recall, the ultrasound waves are such that during a high pressure part of the wave there's compression of these tiny microbubbles, and in the negative phase there's expansion. So just imagine if this is expanded even more and more. If you have a high mechanical index, and high certainly is above 1, and we'll talk about that, then you will tend to burst these bubbles. And that's why the settings on a machine have to be well tailored for contrast preservation, so you won't destroy too much of that contrast, and you'll see then a lot of destruction of these contrasts coming to the heart. So high power in MI greater than 1, low power less than 0.3 or so. So remember those. And nowadays you could do a lot of presets on these machines to be able to do it appropriately and enhance the images when you use contrast. Now, a few examples also. This is how a change in mechanical index can affect your image. I've put an arrow towards the mechanical index, and it is quite high here to start with at 1.5. Notice what happens when we start bringing down this mechanical index further and further. So it's high, and you could see a mixture of contrast and non-contrast images here, enhancement. And then we're going to start bringing it down, and by just bringing it down simultaneously, you're going to see much more filling of this heart. And hopefully many of these are preset already on your machine, so the mechanical index for contrast should be low for enhancement, appropriate enhancement of these contrast agents. Okay. So next, what we're going to show is, and these are some nice examples of contrast enhancement, and you could see it very nicely here. The other thing is to keep in mind is when we talk about harmonic imaging. Interestingly enough, harmonic imaging, right, is you send at a fundamental frequency and you listen or record at multiple of those frequencies. So contrast agents, actually, since these are tiny microbubbles, they resonate so much, and they emit second frequency, or multiple of those frequencies, so that for optimal visualization of the contrast as opposed to the native images, we use harmonic imaging. So let's take a look at that here. This is fundamental versus harmonic imaging. This freeze frame is actually at fundamental imaging, so there is already contrast in the cavity, but you really cannot differentiate well the cavity itself from the myocardium per se. And notice here for this machine, it says on the display harmonic imaging versus non-harmonic, and you'll see the change. Just with this switch of a button, you will see the change of the image quality, meaning when we go on harmonic, we got to enhance so much the contrast per se compared to the myocardium. So off, on harmonic. Look at that difference. So basically the same settings otherwise, except harmonic off and harmonic on. Again, nowadays, as opposed to in the past where you had to do it manually, many of these are preset already. to optimize your enhancement of the images with these contrast enhancing agents. Okay, so let's go through some of the applications basically. So in summary, for the first portion is, yes, there are available, at least in the United States, 3 agents, and we use them interchangeably. We have them in our laboratory, and they're equivalent from their applications and efficacy of enhancing the agents. 2, remember the settings on your machine to make sure that the mechanical index is low that you use with harmonic imaging. Now the applications are, and this is what's approved from the FDA, endocardial border definition. If you have more than 2 segments that you cannot see, this is the prime indication. The others have not been approved for such indication, including stress echocardiography, so enhancement of Doppler signals, myocardial perfusion, and therapeutics. Certainly this area is still under investigation and insulin research. So if you take a look at what has been published from the American Society of Echocardiography, this was the first document in 2008, and this is an update of 2018, so just recently, and I would encourage you to take a look at that because it has a nice summary of indications and applications of contrast echocardiography and use of ultrasound enhancing agents in the echocardiography field. Number 1, as I mentioned earlier, improved endocardial border definition, regional as well as global. With that also comes delineation of hypertrophy. You really can rescue uninterpretable studies from the ICU, particularly improved stress echocardiography. This is not a clinically approved indication, but certainly very helpful for the same principle, basically. Doppler enhancement and definition at times of structural abnormality. If you're really not sure that there's a thrombus or a connection between the ventricle and a sac with maybe a pseudoaneurysm, I think these are very helpful utilizations of ultrasound enhancing agents. Now, from an appropriate use criteria, this from 2011 and still holds till the present, is that certainly appropriate indications are the selective use when you have 2 or more contiguous LV segments that are not well seen, and routine is certainly not appropriate for every patient that we do. So take a look at this. Usually I like to show this case because in a regular audience we would poll them and see what is the ventricular function, is this normal or abnormal, and the audience is usually split, and you can make your decision whether the heart is functioning normally, and this is your answer. And the same patient using ultrasound enhancing agents, take a look at that. Ventricular function is very nice and normal. The pictures early on deceiving, and you really should not interpret that. I do hope that your laboratories nowadays don't end up with an interpretation on their echocardiogram for the left side to say uninterpretable study, meaning that I would like to push you to make sure that you use ultrasound enhancing agents appropriately in each one of the laboratories. And I think this is very important also to have the equipment with settings and harmonic setting for you to be able to see that. Take a look at this case here, a depressed ventricle. Certainly you could, I think most everybody would agree, we don't see all the walls. We can say globally it's depressed, the ejection fraction is depressed. Cannot say much more really regarding that. And look at, besides depression of ventricular function, I can look at all the regionality, and basically this is diffuse abnormalities except the apex, which is akinetic, and on top of that you see a non-enhancement of this structure, which is a thrombus, which changes obviously the management on such patients, and hopefully you improve outcome by putting them on anticoagulants. Take a look at this case here. Just looking at the descent of the base and maybe a motion of the lateral wall, I would say, this is most likely a hyperdynamic ventricle. I cannot say much more than that. I'm wondering about whether the apex is dysfunctional. Could it be akinetic? Again, please, use contrast appropriately and not end up with a lot of questions on your report if you don't use it appropriately. And notice here in this situation that indeed this heart has a hypertrophic cardiomyopathy with a septal prominence, and the apex is not sequestered, actually is functioning very well. So a major change in your diagnostic capability, and basically if you don't see, you're going to end up with a lot of question marks. If you see it correctly, then you can make a diagnosis and give the appropriate diagnosis. Take a look at this case here. Hopefully it works. Maybe it's not working. That's okay. Even on a still frame you could tell. I could not see here anything here, but on this still frame you could see an aneurysmal dilatation in a very unusual situation, meaning in the middle of the anterolateral wall. So at times we extrapolate, and I read this patient as normal before because my eye extrapolated this area here to be normal and didn't see much in the anterolateral wall. And got a call from our colleague and said, the EKG is very abnormal. And that was in the early days of contrast and ultrasound enhancing agents. Take a look at this EKG on somebody coming with chest pain. Could be ischemic, it could be an apical hypertrophy. You really can't tell from this, but certainly very abnormal. And on your echocardiogram, somebody coming with chest pain, you wonder about the apex here, whether this is abnormal, yes or no. Most likely leading towards abnormality, but that's all what you could see. And if you could use contrast, this is apical hypertrophic cardiomyopathy with some sequestration of a very tiny cavity, so the wall motion of the apex is still abnormal, but you could see the diagnosis is very different than what you had expected without the use of contrast. Let's take a look at this and see. Hopefully these clips would work. They're not working. That's okay. Oh, for whatever reason, we're having some issues with clips, but you could see this apical hypertrophic cardiomyopathy. I wanted to show you actually that this apex here appears, full, and the epicardium was not functioning as well, but you had to use some enhancing agents for you to be able to see the myocardium really nicely, to be able to open up these basically see the endocardium well and see the apical trapping of this hypertrophic cardiomyopathy. Notice also, even on this still frame, that you could see the arterioles coming in, through the myocardium. All right. For whatever reason, it looks like we have for whatever reason, our okay, well, we have some issues and technical issues. That's okay. We can live with that. How about stress? Okay, this is, we talked about some of the applications. This is, baseline. And this is in baseline of a normal individuals, a rest, low dose dobutamine, max dobutamine, and you could see the hyperdynamicity of this ventricle. This is a very interesting case I recall very well. This is somebody who had chest pain recurrent, had bypass surgery before and was cathed, and the catheterization showed basically normal grafts. However, the native circulation, which was not bypassed, progressed, and this was like a ramus branch, and you could see where the abnormalities here. The heart got more enlarged after the 10 mics, and so this is the 30 mic of dobutamine with regional abnormality. Yes, it's very important if you're going to use contrast enhancing agents here, is to use them at baseline, so you have to make a decision whether to use it, yes or no. We know that during stress the quality of the images may go down, so you have to make that decision also and err more towards the side of using ultrasound enhancing agents in those situations. Now, current utilization, I made this slide many years ago, and it's still basically this, but we have many more laboratories nowadays using ultrasound enhancing agents for use during stress echocardiography. Who are the patients who benefit, and are they cost effective? And I think these are important. We did a study several years ago with Juan Carlos Plana when he was a fellow here with us. So time is flying indeed, more than 10 years ago. And this is a randomized trial of patients who would get enhancing agents. So patients got 2 dobutamine tests, one with and one without ultrasound enhancing agents, and compared it to angiography. And a few things that were relevant. One is that the image quality stayed high as opposed to degraded during dobutamine from rest to peak stress. So that's important actually to know. 2, from a diagnostic accuracy compared to angiography, is that if you didn't have 2 segments or more non-visualized, your accuracy without enhancing agents is really very poor. Concordance is much higher during. And if you were able to see the vast majority of the segments and either all or just at most 1 or 2 segments, you're able to still get a very good diagnostic accuracy for these. So take a look at this case, for example, right? This is a patient with and without ultrasound enhancing agents, so 2 different stress modalities from that particular optimized trial. So you tell me how much, what kind of diagnosis do you get at baseline? Is there a wall motion abnormality? And during stress. Now I see some wall motion abnormalities here. The question, are they all de novo, and what's the extent of that? It's really very hard to tell. There's no question about it. So you would be guessing if you're not using an ultrasound enhancing agent. Now if I use an ultrasound enhancing agent, 2 things happen from my diagnostic point of view. 1 is at rest, at baseline, there is already an apical abnormality. It's almost like a small aneurysm in the apex, right? Do you agree on that? Now with increasing dobutamine dose, 10 mics, 30 mics, notice that the ventricle has enlarged at end systole, and also the wall motion abnormality has extended beyond just the apical abnormality that we saw. And when did it occur? It started occurring at 10, so you can also time it, and certainly quite a bit prominent at 30 mics or so per minute. Okay, now a few things are important when you use ultrasound enhancing agents. One is that you have to be careful from contrast. Yes, it improves our diagnostic accuracy and our ways to see things, but whenever you start seeing linear structures, you see this linear blackness, if you will, attenuation, be careful, because then it starts hiding the endocardium behind it. See, the endocardium is way out there as opposed to here. So be careful when you use ultrasound enhancing agents to either miss a diagnosis or be shadowed by these attenuation masking. This is important here in this case. Take a look at that. You would think that the inferior wall is normal here. This is max dobutamine. But actually the endocardium is way behind here, and actually no thickening is occurring. You start suspecting it right here, right? You notice that? At baseline it was contracting normally. At low dose, yes, but even at 10 and above, there's an abnormality. Don't be fooled by these shadows here. Don't be fooled that they are the endocardium, because they're not, okay? So this is for stress echo. It improves the endocardial border definition. It translates into improved accuracy, certainly. Appropriate use of contrast in stress echo ranges between 50 and 80% of studies, depending on the population that you're really studying. And you know, are they the vast majority difficult and have lung disease versus others? So make that judgment at the baseline study, and you still have to optimize, obviously, the image. Make sure that you don't foreshorten the ventricle and get, you know, your best studies. What is the impact of ultrasound enhancing agents on diagnosis and management of patients? This is a study that we did when Mohammed Kurt actually was a visitor from Turkey with us. Now he's a physician practicing in Turkey, and that was quite a few years ago, more than 10 years ago. And what we did is took 600 some patients, consecutive patients, who required enhancement with contrast because of technical difficulties, and basically did the study and did contrast towards the end, and we called the physicians with the report of the unenhanced study and asked them about what they would do, and told them what the results were after we interpreted the enhanced study with contrast, and see how they would change their management. First, about these are individuals obviously in different settings, inpatients, medical intensive care unit, surgical intensive care unit, in the outpatient setting, that required an enhancement, right, with these agents. And the decision, as usual, and I do hope, is done by the sonographer or whoever is doing the study, because you want to lessen the burden of how to get that approved and administered. By definition, we wanted these studies to be inadequate, so it was reinterpreted. So the vast majority were technically difficult to start with from an interpretation of regional and global function. And about, some of them were truly uninterpretable whatsoever. So, and you could tell that in the inpatient ward, in the surgical intensive care unit, about 20% were completely uninterpretable. And the others were obviously of a lesser degree. Now the interesting thing is, after ultrasound enhancing agent, the conversion to an adequate interpretation doesn't tell me much about the valves or other things, right? But this is adequate interpretation of global and regional function was in the vast majority of patients. It's not 100%. And you could see here that in the surgical intensive care unit, which is probably the most problematic with so many instrumentation on these patients after surgery, is that we still had about 20% of those original who were technically difficult to interpret, global and regional function. But notice the difference here. We had 20% who were completely uninterpretable to start with. So quite a bit of an effect on the adequacy of images that we see. Now the impact on additional planning of procedures was also significant. Notice that TEE for interpretation of ventricular function in somebody who was either hypotensive or some not doing very well, avoidance of about 30% of transesophageal echocardiograms in the surgical unit, right? And nuclear imaging avoided, and no procedure change. Yes, in the vast majority, almost 50% of them here, we didn't change much but obviously you had confidence as to what ventricular function was in managing those patients. And there was an indication, a reasonable indication for why to do an echocardiogram to start with. And not unexpected, right, is that the impact is less in the outpatient setting if you have a patient population that is overall, less problematic from an imaging point of view. So the highest impact from a change in planning procedures is in the intensive care units, a little less in the inpatient wards as well, and the least in the outpatient setting, but still about 10% or so. Now, the impact of medication change, here you go, hemodynamic drug started in blue, hemodynamic drug stopped. You could see that because it was the right call when you now know what the ventricular function is. And at times you see something that is suspicious for a thrombus, or you may not see anything. Anticoagulation started in about 5 to 15% or so of patients. Anticoagulation stopped because there was something suspicious about a thrombus, and if you just stayed at that level, anticoagulation would have been started in a ventricle, that is. So this is the total impact on patient management. So total impact of either changes in procedures or changes in medication, the highest, actually the majority of patients are in the intensive care units, and the surgical intensive care unit number 1, medical intensive care unit second, inpatient ward, right? So an impact of about 30-some%, and the least impact of about 12% in the outpatient setting. So this is your total impact there. Now we asked another question in that same population, is that, and it made sense. We asked, Dr. Kurt to do this analysis. If we had 2 to 6 segments not well seen, or higher number of segments that were not seen, the impact on change in approach or management or diagnostic, studies that you needed to do is, intuitively higher the less we see of this ventricle with non-contrast images, non-enhanced images. So a few questions for you to decide at home or wherever you are in your office. Is this thrombus versus reverberation? Can you tell? You make that decision. Obviously for these we do multiple windows and scanning, short axis of the apex. Okay, let's take a look at that. Interesting. None seen, and that was a major reverberation there. Quite impressive. How about this person? Thrombus versus trabeculations. Can you tell? Depressed ventricle with apical wall motion abnormality. Let's see here. There you go. You can see it actually nice layered there. This is not foreshortening of the ventricle. This is a nicely layered thrombus. Thrombus or reverberation, what can you tell here? Quite impressive. This didn't look too impressive at first, right? But just watch it. It is quite impressive, and actually there may be other fragments there of that thrombus. Quite impressive. Okay, so we talked about endocardial border definition and enhancement of Doppler signals. I think is important. Myocardial perfusion. In myocardial perfusion, I'm not going to spend too much time on it, but these tiny microbubbles actually have been shown very nicely by Jonathan Lindner and Sanjeev Kaul and Kevin Way and Tom Porter, that particularly that they can go unhindered because of their size in the capillaries as well as the venules, right? Because of their size. So you would think that if by enhancing the myocardium, you'll be able to take a look at myocardial blood flow, if you will, and actually quite a few studies have done that. This is continuous imaging. Obviously, with a continuous imaging, you're destroying most of these, microbubbles, because the velocity in the microcirculation is really very small. So that velocity, those tiny microbubbles are exposed to ultrasound, quite frequently, and therefore can get destroyed. So if you do this intermittently imaging, you could see that there's quite a bit of enhancement of the myocardium per se. And actually, some of these mechanical properties or interaction of ultrasound at the myocardial level, which is very different than in the cavity itself. This is early work from Dr. Sanjeev Kaul, that if you actually destroy with a high mechanical index and then start imaging intermittently afterwards, you can replenish the myocardium with contrast, and therefore you can actually determine myocardial blood flow velocity. The higher this slope, the higher the velocity of red cells coming through the capillaries into this situation. And that has been shown very nicely, and many years ago, that you could do that. This is a great technique for research. And the beauty of these techniques for research is that you could do multiple injections after various interventions, and you're not left with any residual, meaning if you use microspheres that are labeled, you can't use too many. And here, so you could do any manipulation and quantitate basically myocardial blood flow. And you could do real-time imaging actually with a low mechanical index and a slow frame rate, so you're not destroying as much. And this is, and intermittently you could do a high MI, destroy it, and then watch it replenish, right, with intermittent bursting. And this is from early studies we did in our in our laboratory. You could see the high mechanical index destroying the microbubbles and then gradually replenishing. You can see that nicely. At times there are attenuation artifacts in the far field, and this is some of the issues that we have with myocardial perfusion, but you could see it very nicely there. Now notice, after dipyridamole in this individual, one that we don't have as much myocardial blood flow in the apex. And notice now when we do destruction and replenishment that, you know, the slowness of the myocardial blood flow going into this ischemic so because you have a larger wall motion abnormality when you use dipyridamole vasodilator. Okay, so and these are, you know, several studies looking at sensitivity and specificity of you know, of perfusion compared to SPECT, compared to coronary disease, etc. But I think the important thing is, yes, this is a technique that you can take a look at myocardial perfusion with it. It is technically demanding, there's no question about it, that you have to be very careful about the technology itself. There are some attenuation, some false positivity, particularly in the base, and I think at this stage it is not approved for clinical use, although we can use it, you know, because contrast is used for stress echo again. So we could use these technology. The other things is taking a look at, here you go, use in the vasculature. You could see that here in the cerebral, you know, the carotids, etc. People have looked at also vasovasorum imaging and see whether it can help you in deciding for atherosclerosis activity or healing. And I think these are great areas for research. So I wanted to conclude and give you a feel of future directions in the field. Number one, I think nowadays, I mean, looking back at the field itself over the past few years, one, that education has really paid off. It has been slow overall for adoption, if you will, of ultrasound enhancing agents. But I think the more we know about, number one, safety, availability, as well, most importantly, diagnostic impact. The diagnostic impact because of quality. We're doing these studies anyway. We want to make sure that you get the best diagnostic yield out of these ultrasound enhancing agents or out of echocardiography per se. So please use these appropriately, and there are appropriate use criteria and recommendations using the guidelines and the statements from the American Society of Echocardiography. And we appreciate also the various forums, including this one, for you know, basically spreading the word on how to, in addition to where to do ultrasound enhancing agents in echocardiography, because it will address the wide variation, and it is less and less, and the appropriate utilization. The other thing is, we do hope that our industry partners improve the technology of 3D in relation to ultrasound enhancing agents, because in 3D obviously you're sending much more you know, in the in the field of view in 3D, so you can destroy much more contrast because you're not sending that as just one plane. So we want to optimize utilization as well as you know, visibility of this, so we can, in technically difficult patients, so you can do 3D volumes of the ventricles, left as well as right, as well as ejection fraction and regional function. So we implore our industry partners to improve this pairing, if you will, or marriage of these two techniques, contrast as well as imaging. For perfusion is a different you know, situation. I really think, I mean, we've done a lot of work in this field also in the past, and there are pioneers in this country and in the world that have looked at ultrasound enhancing agents. It is technically more demanding, and you know, up to now it is not approved for clinical use. In my view, it is less competitive compared to other modalities. Nowadays we have PET on board, we have CMR with perfusion, and we have the regular SPECT. So it is much more demanding, and there is some more variability in the interpretation, particularly in the cardiac base, and at times that's important to do that. We have a utilization code. I don't know what the latest on that, but it is an amazing tool actually for research, be it in clinical, but certainly in laboratory field. I think it is an amazing tool for research to look at the vasculature, the microvasculature flows, be it in the heart or in the limbs. So I think kudos to those areas of research. Role in therapeutic and gene delivery. Actually, I heard one of the latest presentations, award presentations in Europe, looking at gene delivery in the brain, the pancreas, and many other places where higher energy is given to these microbubbles, and they could be coated with the genetic material that you want to deliver, and you can burst them at the site and obviously enhance them. Thrombolysis also has been pioneered by Tom Porter. And exploration in vascular imaging, vasovasorum imaging, still, it needs more work in that, but I think it's very exciting. So that's what I want to share with you today. I think if there are any questions, if you want to text, you can text DeBakey. Enter text DeBakey to 37607. Or you could go to pollev.com and enter your message, and we're happy to answer any questions. Thanks again for watching. Hopefully that was helpful.